Good afternoon. My name is Susie McLean. I work at the International HIV/AIDS Alliance. I want to begin my presentation by stressing that this work that I'm going to describe today is a collaborative effort of 3 organisations listed here: Harm Reduction International, an International Drug Policy Consortium, along with the Alliance. It's the subject of our new report here. We have copies available at the front. And there's a launch of the report tomorrow afternoon in the Global Village, the Drug User Networking Zone. So if you're interested in more detail on the findings, or if you want to talk about them some more, we encourage you to come along to the Global Village tomorrow afternoon. I particularly want to acknowledge the significant efforts of my co-authors, in particular Catherine Cook, the lead author, who was unable to travel to Melbourne. So, in this presentation, I want to describe the need for harm reduction services, the gaps in funding, and then some of the trends in spending on HIV more generally, and to draw some conclusions about what that might mean for harm reduction funding, in particular in middle-income countries. There's no time for a description of what harm reduction is or what the global need for harm reduction services is, but just a reminder that HIV transmissions from sharing injecting equipment produce 10% of all new infections around the world, and that figure rises to 30% of all new infections outside sub-Saharan Africa. So this is not a marginal issue, and I'm presuming that you understand the priority of efforts to address HIV and hepatitis C amongst people who inject drugs. First finding, something that you probably all know, coverage of harm reduction services is very low. It's officially low, very low. The data from 2010 shows very poor coverage of harm reduction services, and this is despite compelling evidence from many studies that show the cost effectiveness of harm reduction interventions for people who inject drugs. I reflect on Michael Kirby's much described AIDS paradox and ask, have we got a new AIDS paradox? We've got very poor coverage of services, very strong data on the effectiveness of interventions, yet very low levels of investment. It's one of the most effective and strategic things we can do to end AIDS, yet it remains one of the program efforts that are most neglected. So, how much money is needed for harm reduction? There are a number of ways that the need for harm reduction is counted and described, but I refer to one of the most contemporary analysis of how much money is needed, the UNAIDS Strategic Investment Framework, where the figure of 2.3 billion was arrived at, and I stress that's a figure for 2015. It's not an overall figure, it's a figure for next year. And you'll see on the list that by 2020, that figure is, the concept is that figure goes down to 1.5 billion on the presumption, or on the assumption that investment now reduces the need for investment later. Okay, how much is being spent? And the first finding of our report is that it's very difficult to know. There's no systematic tracking of investment in harm reduction programs by national governments, nor by international donors. The Global Fund has kind of acted as a bit of an exception through though it's proving difficult to understand the Global Fund investments since round 10, but certainly understanding the Global Fund investment is easier than the investment of other donors. There's also a problem about varying definitions of what constitutes harm reduction. So, for example, PEPFAR's categories include activities such as training, community mobilisation, prevention of sexual transmission, but it doesn't include the key harm reduction intervention of needle and syringe programming because of the US government federal funding ban. So it's very hard to compare the spending of different donors. So we argue in the report and here that there's a need for leadership from UNAIDS, UNODC and WHO on this problem, that the technical agencies really need to be producing data that's showing the world how much is being invested in harm reduction and what the gaps are. There's more on how much is being spent. In terms of what national governments are spending on HIV, we know from UNAIDS work that globally domestic investments in HIV are increasing and are equivalent to 53% of global investment in HIV. However, this doesn't apply to domestic investment in harm reduction. UNAIDS also report last year that of the 10 priority countries for harm reduction, investment in harm reduction interventions was less than 5% of overall spending on HIV. So these are in countries where there's a significant amount of HIV transmission amongst people who inject drugs, and 5% or less of spending on national government's HIV spend is going to harm reduction. I wanted to refer to the elephant in the room here. Underpinning many of these resource gaps, I'll come on to some of the resource gaps in terms of bilateral spending, but I wanted to refer to the kind of fundamental inhibiting factor, and that is harm reduction services are politically unpopular often. Governments all over the world struggle with the interlinked problems of high levels of stigma against people who inject drugs and weak or no commitment to harm reduction interventions such as needle and syringe programming, methadone for drug dependency treatment, and policy reform. These stigmatising attitudes are formed around beliefs that drug users are unworthy or are bad or otherwise undeserving of services. And these stigmatising attitudes exist both in public and community discourse and amongst decision makers, and they inhibit investment in harm reduction. The political unpopularity of harm reduction is linked to the international investment. So recognising the underinvestment by many governments, international donors have invested in harm reduction, and this has led to some really important developments in global investment on harm reduction over the last 10 years, where we've seen some very large-scale examples of scaled-up harm reduction programs in countries such as Ukraine, Vietnam and Thailand. But as donor trends shift, we need to pay attention to the precarious nature of this investment. This and the last slide I want to underline as the kind of the crux of the problem. International donors are changing their priorities, as many of you know, and are using really crude measures such as country income status to define what investments in harm reduction should be. This threat applies to all HIV funding in middle-income countries, but what we argue here is it applies in particularly intensely to harm reduction because more than any other key population, people who inject drugs are increasingly concentrated in middle-income countries. So this figure shows that of the 15 countries listed by UNAIDS as priority for reducing new infections amongst people who inject drugs, all but one are classified as middle-income. And the poverty of marginalisation of people who inject drugs in all these countries, including middle-income countries, underlines just how very blunt the World Bank's country income classification is to determine strategic investments to end AIDS. So between some good news, between 2002 and 2010, the Global Fund rapidly became the largest donor of harm reduction services for people who inject drugs. It was one of the most significant developments in global harm reduction. You can see the upward movement of money. However, the Global Fund has changed its funding policy, and there are alarming indications for harm reduction. 58 countries that have received money for harm reduction in the past, 24 of these are now, for harm reduction, 24 of these are now ineligible or will receive no new money. Only 10 countries, 5 in middle-income countries, are eligible for funding for critical enablers, the very work that WHO have defined as vital in its new key population guidelines launched this week. So we have a breakthrough where WHO say critical enablers are vitally important work, just as the funding envelope for that work disappears. We don't have the data on recent and forthcoming investment in harm reduction yet. We're trying to get it. But our analysis is pointing to the fact that that the Global Fund investment will decrease, that the overall amounts have peaked, and that we'll see a decline in investment over the next 3 years. It's important to add when we talk about international or bilateral donor trends, that many of donors are also funding the Global Fund, but whilst the Global funding formula is limiting investment in harm reduction, so too will the bilateral donors' investments in harm reduction reduce. So we know that different bilateral funding is reducing dramatically. It's hard to know what's happening with the Australian government and its funding for harm reduction. We know the Australian government's been an important funder of harm reduction in the past, but we don't know what the future holds. We'd like to point out that the Dutch government are significant in that they're maintaining their commitment to funding harm reduction. And a couple of comments about PEPFAR funding. I've got a slide next that shows what some of the proportions are, but I wanted to make some general points about PEPFAR's trend towards national country ownership and technical support rather than programming kind of sends some alarming signals about harm reduction funding. So you'll see on this slide, I draw your attention in particular to the red column that's showing the proportion of PEPFAR's HIV spend on services for people who inject drugs. In many cases, in many important priority countries, it's a very low proportion. Okay, we've got a set of, to conclude, we've got a set of recommendations. I'll whip through them quickly because I'm running out of time, but I urge you to consider them more directly in the report. They're about keeping the Global Fund global and arguing that we need new indicators to determine allocations for Global Fund spending that pay attention to inequalities, about governments' willingness to pay, that pay attention to the policy barriers for harm reduction, and that address issues about transition to domestic funding more directly. We argue that there's a need to invest much more strategically in harm reduction and that donors need to be investing where national governments won't or can't, and we argue for much more responsible exit strategies of some of the bilateral donors. We ask UN agencies to improve dramatically the data on harm reduction need, coverage and investment. Third recommendation is for national governments to fund their harm reduction programs to ensure the sustainability of harm reduction and to address stigma related to HIV and drug use both in the public debate and in the attitudes of decision makers. Finally, we've got a set of recommendations that are about non-HIV money and that refer to the vast amounts of money that are spent. One of the calculations is 100 billion per year that's spent on drug control interventions. We urge national governments to do some assessments to determine whether this is really value for money and to think about rebalancing that investment towards health and harm reduction. So finally, I draw your attention to the report. You can see where you can get it, and we have copies available here. And yeah, thanks for your attention.